So if we think about the herpetic anterior uveitis, so herpetic anterior uveitis cause about up to 10% of anterior uveitis caused worldwide, and up to 40% of these patients will develop glaucoma at a time due to inflammation-induced raised intraocular pressure. We know multiple infecting agents, including the herpes simplex virus #1, and the oral and varicella zoster virus, and even cytomegalovirus, all belongs to the herpes family, and all can induce infection causing herpetic uveitic glaucoma. Different mechanisms are included in that. The virus replication and the trabecular meshwork trigger inflammation and block the aqueous humor outflow. Also, the trabeculitis induce more increase in ocular pressure. Also, the breaking of the blood-aqueous barrier that lead to protein leakage and also induce more inflammation. In some advanced cases, we have the peripheral anterior synechia, can induce angle closure glaucoma as well. Also, the steroid we're using to control uveitis sometimes also induce these trabeculitis and induce glaucoma as well. Unfortunately, glaucoma will develop during the follow-up of uveitis, and this will happen within the first 4 years. We have different risk factors to develop glaucoma in a patient with uveitis. Repeated inflammations, repeated attacks without proper control, the delay of the antiviral therapy startup, and the poor steroid monitoring. So some patients are still medicated with a steroid. They know they are doing better with the steroid, so they keep using steroid without supervision. And also the lack of compliance in a patient with immunocompromisation. This is a real case. Lady Fatima, she's from Sudan. First I saw her January 2025, and she's bilateral pseudophakia. She was referred to our practice with right eye glaucoma in the setting of recurrent herpes simplex virus with stromal keratitis and uveitis in the right eye. Fortunately, she didn't have any no epithelial keratitis. Her vision was 20/60 was corrected, pressure was 28, anterior chamber shows +2 cells in the right eye. Fortunately, the angle was open. There's no peripheral anterior synechia, grade 2. On presentation, she came with her medication already. She was using latanoprost at that time, fixed combination of dorzolamide and timolol twice a day, brimonidine twice a day, and frequent unsupervised loteprednidone, and a cyclovir ointment 4 times a day. So, an exam, she had already failed trabeculectomy done 3-4 years ago, fair OCT and visual field. So they would have to do some modification of the treatment. So this is uveitic glaucoma, diagnosed before herpes. So latanoprost has no role here. No prostaglandin are advisable. We stopped latanoprost completely and replaced the loteprednol with prednisone acetate, because already she has +2 cells in the anterior chamber. We're using loteprednol. So the penetration of prednisolone acetate 1% in the anterior chamber definitely doing work. And we started the antiviral, started the valacyclovir, 1,000 milligram twice a day for a month for the active phase, and then shifted to 1,000 milligram once daily as a suppressive dose later on. With that, I managed to get the pressure down from 28 to the low teens. After controlling the patient for a few months, I tried to go for preserved flow. I tried to avoid the scar tissue superiorly, so I implanted superior temporally into the patient, and with the microshunt. And I used, as usual now, this is recommendation I was using right now, mitomycin 3.04% for 4 minutes. 3 months later, she maintains the best corrected visually 20/40 with remarkable improvement, pressure 12/13 with no glaucoma drops in the right eye. And she continued to use the prednisolone acetate 1% 4 times a day. This is also routine to keep controlling the inflammation, as well as also to keep the preserved flow blood from failing. And in such a case also we recommend to have this valacyclovir and systemic antiviral for 1 year at least. Follow-up for this patient should be at least a monthly for the pressure and inflammation, keeping our steroid and oral acyclovir, and definitely 3 times a year we have to check the visual field OCT and every 4 months. Thank you.